Good evening, everyone. I'm presenting my paper on evaluation of the impact of short-term manual small incision cataract surgery training program using ICO OSCAR. There's no financial disclosure. MSICS is a widely accepted, cost-effective, and affordable technique, yet yielding similar surgical outcomes in phacoemulsification. Surgical training requires a standard curriculum and a well-structured program for proper implementation of the training. Earlier studies were concentrated more on subjective analysis of the trainee's surgical skill by the preceptor or the mentor. The focus has now shifted to a more objective assessment of surgical competency and assessment tool using ICO OSCAR SICS, which is internationally valid and a reliable tool. Our study was a retrospective observational study carried out from June 2019 to May 2022 at Tertiary Care Eye Hospital in South India. A total of 94 trainees were evaluated during the 1-month MSICS training program using the ICO OSCAR scoring. The trainees were divided into 3 groups. First group was a first year resident group, consists of 17 trainees. They were the first year postgraduates with no prior SICS experience. The second group was the fellows, 64 trainees who were enrolled in the post residency surgical training in the institute and lasting 1.5 to 2 years, and they had varying prior SICS experience. The third group were external trainees who were practicing ophthalmologists from other centers having varied SICS experience, who were enrolled in this 1-month training program. This 1-month training program is a dedicated surgical skill transfer program which involves hands-on SICS training along with wet lab training, operating theatre observation, lecture classes on SICS, virtual reality cataract surgery simulator training, and also one-to-one discussion sessions on surgery after each surgical OT. Patients having age-related cataract grade 2 to 3, well-dilated, prominent eye were selected, and all complicated cataracts or non-case of glaucoma, corneal or retinal pathologies were excluded. Patients with deep socket or systemic high-risk patients and patients with postural abnormalities were also excluded. All trainees performed SICS with IOL implantation under subtenuous anesthesia under continuous observation by the trainer through observer eyepiece and display monitor. If the trainee noted difficulty in performing any step, it was rectified by the trainer so that the trainee could proceed to the next step without compromising patient safety. Any major intraoperative complications like scleral disinsertion, premature entry, posterior capsular rupture, and sound dialysis were managed by the trainer. All the trainees maintained a surgical logbook with ICO OSCAR scoring for each case. The OSCAR sheet was duly filled by the trainer after completion of each case. Complications, if any, were also noted and discussed with the trainee. The data entered on the OSCAR sheet was evaluated for surgical skills by calculating average mean scores and improvement in mean scores in the last 5 cases as compared to first 5 cases. Scores in the first and last 5 cases were considered as the initial and end mean scores respectively. This is a sample of ICO OSCAR scoring sheet which is used. A total of 1,842 patients were operated by the trainees. The mean age of the trainees were 31.40 plus or minus 5 years. Average number of surgeries was 19 surgeries per candidate. Each case was divided into 18 steps where the prolapse of nucleus into anterior chamber and nucleus delivery was marked as single step. A maximum of score 5 per step and total maximum score for one case was 90. Coming to the results, there was a statistically significant change in the scores of the first year residents from the initial cases to the end cases. In the beginning of the training, the difference between the scores of the first years and the other groups were statistically significant, but towards the end of the training, there was no significant difference between the 3 groups. Learning curve was evaluated by plotting the mean scores in set of 5 consecutive cases and observing its trend. As per seen in the diagram, the first year residents shown in the blue mark shows significant improvement in scores after the 10th case. Even though the fellows and external trainees started off at a pretty higher scores, they had some improvement, but it was not statistically significant. Sub-analysis of tunnel construction and capsular access was done. The first year residence shows significant improvement in capsular access. Even though there was increase in scores in the tunnel construction, it was not statistically significant. Complication profile included the most common complication was in tunnel construction, mostly in they made premature entries, and external trainees had a higher complication of PCR and ZD. Surgical skill assessment is necessary to know the progress made by the trainees and to improve the training program as well. Several tools were used in the previous studies like OASIS, GRASIS, and surgical video assessment. ICU Oscar SICS provides objective benchmarks for comparative purposes. Lower mean scores of the first year residents can be attributed to their lack of prior experience, but showed significant improvement in the learning curve during the 1-month program. The difference in mean scores between the groups significantly reduced towards the end of training. It means training helps the trainees without any experience to improve their skills. Tunnel construction and capsule access contribute significantly to the surgical learning curve, and most common complication was a premature entry. External trainees had a high rate of PCR and ZD, which could be attributed to their previously improper acquired surgical techniques, which needed further unlearning and relearning. Thank you.
So what do you recommend for the residents now after this study? What do you recommend?
Sir, proper 1-month training in a well-structured program will help them to form a proper basis on which they can further build up their surgical skills under supervision. And this would help them to do cases with lesser complication rate.
Your average age means the trainee's age, you know.
Yes, yes, sir, yes, sir.
Actually, initially I was looking at this thing, number of cases, then average age. So suddenly I thought,
Yeah, the trainee will be senior.
yeah. Okay, that's for just for this. But you should have mentioned it properly. Okay. Second thing is, the fellows also you included, no?
Yes, sir.
They didn't show much improvement. That means it was in between 1 month you have taken. So that's it. Say the fellows were doing surgery.
Yes, sir.
Yeah. For this scoring, you took 1 month period.
Sir,
All others, it was different criteria.
1 month for short-term trainees.
yeah.
1 month for fellows who just started. But for fellows, it is a random.
So
No,
Fellows who
sir.
have finished.
Fellows also you took at the beginning of the
Beginning of their fellowship, sir.
okay.
So every fellow undergoes this 1-month training at the 3rd month of their course. So
Okay.
after that only they'll start operating.
But there was no not much improvement in that group, no?
Yes,
So that's why they are already trained.
They start.
They already started.
After 16 to 20 cases, if you see there's a difference,
Yeah.
they get overconfident.
Sir, yes, sir.
Overconfident. After 20 cases, they become open, then you have a dip. That is a pattern which we are seeing.
Okay, thank you.